In this video, we're going to be looking at the use of cognitive behaviour therapy for the treatment of schizophrenia. So as stated in the specification, we're going to be looking over the next few videos at CBT and family therapy used in the treatment of schizophrenia, and then we'll look at token economies used in the management of schizophrenia. So, cognitive behavioural therapy, we've come across this before in the psychopathology topic when looking at psychological or cognitive treatments for depression. Here we're looking at a really specific type of cognitive behaviour therapy, which is CBT-P. The P stands for psychosis. This isn't just prescribed for schizophrenia, but really any psychotic disorder. So that could include bipolar disorder, very severe depression with delusions, postnatal depression, where psychosis is common, sleep disorders, which can also lead to psychosis, and just high levels of anxiety and stress. So it's prescribed for a number of different disorders, but of course we're only interested in the treatment of schizophrenia here. And this is the main psychological treatment for schizophrenia. In terms of the sort of practical elements of CBT-P, 16 sessions is the recommended number of sessions for schizophrenia in the UK. It can include group or individual sessions, although the recommendation is for individual, so one-to-one sessions with a therapist. And as we know, quite often with these psychological therapies, drugs are prescribed first to help improve the insight, to help the patient to be able to reduce, in this case, positive symptoms like delusions and hallucinations, so that they can access the CBT a little bit more effectively. We often see in CBT, and in the case of CBT-P certainly, we often see diagrams and drawings to help display the links between potential triggers here and then the symptoms, so auditory hallucinations in this case. So the link between those triggers, those symptoms, and then their thoughts, their behaviours, and their feelings. Because in CBT, we recognise that, okay, we might not be able to stop the symptoms. These auditory hallucinations may persist, but what we can do is help to reduce the triggers or the stresses that might make these symptoms more frequent or severe. But we can also help change how a person thinks about those symptoms and therefore change their behaviours and their emotions as well. And this is using a bit of a stress vulnerability model. Which is basically highlighting the relationship between stress and the symptomology. And it also helps to sort of normalise the experiences of somebody with schizophrenia as well. Because if we're saying that at high levels of stress, these symptoms are going to be common, whether you have schizophrenia or not, then that's going to help normalise those experiences of the sufferer. So CBT, the aim of CBT is really to help the sufferers by changing some of their maladaptive thoughts, that's the cognitive element, and their distorted perceptions to help modify hallucinations and delusions. Again, we're recognising that we can't necessarily eliminate hallucinations and delusions altogether, but what we can do is alter the sufferer's response to these particular symptoms. If we can change how they think about them, then we might be able to influence their behaviour and their emotions as well. So what we are really ultimately trying to do is to reduce the stress and the disability associated with schizophrenia. Part of CBT-P involves making sense of symptoms. So if the person can understand what might be causing particular symptoms, so for example, that could be highlighting particular triggers that make them more likely to have hallucinations, for example. Or it might be explaining to them that auditory hallucinations may come from malfunctioning speech centres in their brain. It could be disorganised behaviour stemming from issues with central control. If we can explain to a patient that there's a cause for their particular symptoms, then even that can just be hugely beneficial. For example, if a person understands that hearing a demonic voice that's criticizing them comes from a malfunctioning speech center in their own brain and therefore can't hurt them if they ignore it, that's going to be much less frightening, much less debilitating. It's going to decrease their anxiety and it's going to help them function much better. So just understanding what's causing the symptoms can have a huge benefit. And then a large part of CBT and what we're going to really be focusing on here is the reality testing. We can't change the experience of hallucinations or delusions. We can't eliminate them. But what we can do is consider how they think about them and ask them to basically outrank, be able to explain, reason, justify, rationalize why they're experiencing them. And that can therefore lower their anxiety as well. So some more specific strategies that are used in CBTP. The first is the reality testing. This is the largest component of CBT. So this is just like in CBT for depression. We're trying to treat thoughts as hypotheses. And in this case, we're really thinking about delusional thinking. So this could involve the therapist confronting a patient directly with some gaps or contradictions or inconsistencies in their accounts to just highlight the fact that they are thinking irrationally. Or perhaps a kinder approach would be reassuring the patient that, okay, their perception of events, that's logical, and that would help calm them. But maybe the therapist could just be a bit curious or maybe a bit confused, or maybe say, okay, it seems like I'm missing something because I don't quite understand what you're saying. And so then the patient's going to need to further explain, and through that, they might identify the gaps in their own thinking as well. And so together, through collaboration, through discussion, the patient and therapist can identify that a thought might be illogical and then can help replace it with a more rational belief. So if we just go back to that previous slide, some questions that the therapist might ask, okay, well, if that voice that you're hearing is real, why can't other people hear them? A question like that might get them thinking about the rationality of their beliefs. And a key strategy might be helping the patient to consider the likelihood that their delusion is true. So just to sort of elaborate that on a little bit further, the therapist might help the patient to engage in specific behaviours that will help them to test out their beliefs against reality. So, for example, the belief might be, just skipping forward a little bit, that the kids at school are sending me messages. That's a belief that we're going to treat as a hypothesis. In this case, the kids were sending messages telepathically to the student, almost like thought insertion. So that's what we're treating as a hypothesis. So now we need to make predictions about that we could then test against reality. So then we can develop a little experiment to test this out. If that were true, then we would expect what? Okay, so what would be a good way of finding that out? How could we develop a little experiment to test that out? What information is actually needed? How might we measure that? So it really is like an experiment. And then after the experiment, okay, how much do you believe that thought now? To what extent were your original predictions confirmed or disconfirmed? On the basis of the experiment and its findings, what's the most realistic and helpful view of this particular situation? So if we can test out these beliefs and treat them as hypotheses to then be tested using an experiment, then we can gather evidence and we can perhaps change that belief when the available evidence just doesn't stack up. We need to rethink our beliefs because evidence doesn't support them anymore. Another key part of CBTP could be challenging the meaning of irrational thoughts and beliefs. So, for example, somebody might believe that their friends are trying to poison them, and they know this because their water tasted funny ever since their friends last visited them. So perhaps we need to challenge the meaning of that and maybe need to consider less threatening alternatives. So, for example, your friends came to visit you last when you moved house. It was a housewarming party. Could it be that there's a new water supply and the new water has more minerals in it and that's why it tastes funny? And so that's going to be much less threatening, that's going to decrease anxiety, and that's going to improve functioning. Some strategies could be just distracting the person from their intrusive thoughts. So this could be through behavioural activation, which we know about through CBT for depression, and that's encouraging them to get involved in pleasurable activities that they might not engage in anymore. Part of CBT is about improving social engagement and skill development. So this is going to help to deal with negative symptoms like avolition. And the therapist and the patient might work together on specific skills, like skills to do with social interactions or occupational skills to do with a job, and also what's going to motivate them as well. And the therapist could set homework assignments for meaningful activities. Things that maybe once brought them pleasure or things that are going to help them in the future. They might ask them to predict how pleasurable that's going to be. And then they can come back and they can actually rate how pleasurable it was. And that way we can kind of change the patient's expectations about these things, and that could encourage them to engage in them a little bit more often. Some other ones, relaxation strategies, that could be obviously sort of breathing, or it could be the removal of triggers and stressors. And also recognizing the signs of relapse so that the person can seek further treatment if necessary. So what I would like you to do, either at this point or after the video, is to read through this transcript. Here we have a therapist, Tony, and here we have a patient with schizophrenia, Caesar, and this is a bit of a snippet from a CBTP session. And I want us to really think about here, what specific strategies is Tony using? How is Tony helping Caesar to either think about something differently or perhaps behave in a different way? And maybe we could think back to that stress vulnerability model here. So together, Tony and Caesar could come up with a little bit of a diagram. So his beliefs in response to a particular symptom, and then how those beliefs are influencing his behaviors and his emotions. So together they'll be able to see that interplay and that relationship between symptoms, stressors, beliefs, behaviors, thoughts, and feelings. And then together they're going to explore the evidence. So they're going to treat this thought like a hypothesis to then be tested. They're going to then develop experiments where they can test this out. And then they're going to weigh the evidence for and against that thought being true. And this can be done by the therapist by sort of gently pointing out the inconsistencies or fallacies in the patient's belief, by suggesting alternatives, or perhaps encouraging the patient to offer some alternative thoughts themselves. Because remember, to experience a delusion like this, that's going to be due to reacting to something really puzzling or threatening. So this delusional belief is due to hearing a threatening voice. That's confusing. Obviously, we're going to be frightened or anxious or confused when we have that experience. So offering alternative explanations to make sense of those threatening voices, that could help reduce those feelings of anxiety, and that could be really helpful for Caesar here.